So I know we're going through a range of different topics tonight. I'm trying to answer many of the clinical questions that I've had over the last few months. So moving to calcium scoring. In practice, I'm seeing, on this slide here, we're talking about age range of 40 to 70. And this is not, we don't have a very good consensus on this right now. Groups are working on this. There are a variety of opinions. And something that is not the guidelines, but what I'm seeing in practice is many clinicians are adding in 10 years before first degree relative diagnosed with coronary artery disease. So if a patient's father had an MI at age 46, it would not be unreasonable to start screening that patient at age 36. There are many benefits to a calcium score, but you need to be aware of the limitations of this. So while I personally feel this is a great screening test for many patients, when there are symptoms, it's not unreasonable to be having a coronary CTA. So where does it fit? Most guidelines would consider a calcium score to be screening for the asymptomatic. A calcium score can be informative, but there are well-documented boundaries for which this is true. If a disease is found in that population, there's often a need to look at additional imaging, such as a coronary CTA, particularly in symptomatic patients. I did want to highlight some of the limitations on this graph here, looking at patients with obstructive coronary artery disease, particularly in different ages. So if we look at, say, the less than 40, if you had a calcium score of 0, a little under 60% of patients who had obstructive coronary artery disease in this age range had a calcium score of 0. So if a patient came into the ER setting and they were symptomatic, that's why they're here with chest pain, and one was to entirely rely on calcium scoring as a way to say whether or not they need further workup, would you do a good job a large percentage of the time? Yes, but it's certainly not going to catch all those patients. So most people are using calcium score in the screening test based on today's literature. If new literature comes out supporting in the diagnostic capacity, we'll certainly discuss that on future webinars. Something I think is extremely important about calcium scoring, and as a group, I've seen calcium scoring just take off over the last 5 to 10 years, very high volumes, and rightfully so. Are people starting to actually look for coronary artery disease? But something I want to spend a moment discussing is if a patient is being treated with medical therapy, it is not necessarily a bad thing to have your calcium score increase. This is why you do not follow a calcium score that's greater than 0 if you are being treated medically. You want plaque to actually calcify and stabilize. You're essentially turning a high-risk non-calcified plaque into a more stable calcified plaque. Now, a question that has come up on multiple different presentations that I've given by someone in the crowd, so I'm just going to address it heads on, is can a calcium score go down? Now, I have never actually seen a calcium score legitimately decrease on follow-up imaging. Now, there could be small fluctuations based on scanning technique, and lo and behold, I've had providers come up and say, well, I had this patient that has a calcium score of 330 using a Gaston measuring, and they followed up in 2 years and it was 270. It went down. Dr. Cords, you are wrong. And I reviewed the images with them, like, here's the motion. Here is the reason why. A Gaston is volume averaging. That you have to understand the methods which are being utilized. You're using 2.5 to 3 millimeter thick cuts. This is not your 0.6 millimeter. The way to look at it is via plaque analysis. I have not seen legitimate calcified plaque decrease in an extent using high resolution coronary CTA plaque analysis over time. And again, you may not want that to occur. So when a doctor has a patient and you start them on statins and their calcium score goes up, if you were to follow that 2-3 years from now, and it went from 300 to 400, is not that statins now did not help that patient. In fact, they may have, because now you converted the high risk plaque to lower risk plaque. So keep that in mind when it comes to follow-up follow-up calcium scores. Patients that might get follow-up calcium scores are those that had a prior calcium score of 0. Most clinicians would not follow a patient that had a calcium score greater than 0 if you were also treating them medically.